Hello.
Good morning.
Good morning, ma.
Please, I just wanted to check, is iPad Dr. Azogu? I can't remember who iPad was the last time. Person showing as iPad.
Good morning.
Good morning, sir.
How's the family?
Fine, sir.
Okay.
Yes, sir.
Dr. Gary, good morning.
Good morning, Doctor.
And congratulations on
Prof.
your listing among Nigerian
Yeah, I
authors.
didn't even know. I didn't even know what was going on. I think some busybody just decided to do some search.
All the same, it's okay. It's okay.
It's okay.
It's
Yeah,
okay.
it's okay. Thank
It's
you.
part of it. Irrespective of whatever criteria they are using, it's still okay.
Exactly.
How's Ramadan?
Alhamdulillah. It's going on well.
But I want to believe that whoever is using iPads will be able to tell us.
Good morning.
Oh,
okay, it is.
Ogwevi.
Yes, it's I.
Ogwevi.
Please,
My mind
allow.
was with you a few days ago. In fact, it was like, could I check on you? Why going on? But I forgot.
Okay, sir.
I hope everybody's fine.
We're all fine, sir.
Well done.
Thank you.
Hello? Yeah. Uh-huh. Yes. Mo busy báyìí, mo busy, mo wà meeting báyìí. Mo wà meeting báyìí.
Prof, can we start?
Dr. Ayedi and Dr. Asogu. Ayedi had been studying for you since, so maybe Dr. Asogu should take over.
Yes, I think we can start.
Okay.
Dr. Ejeba, please, you can start, okay? Yeah.
Okay, sir. Good morning, consultants. Good morning, senior registrar, my fellow registrar. I'm here to do a grand round presentation. Actually, this patient was not clerked by me. He's a patient managed in Iowa University in US, but we decided to present this case because we see a similar case in this environment. We wanted to know if there is any difference between how we manage the patients here and how they manage over there. The usual presentation is a patient will be clerked and questions will follow. So I don't know if I should run through the presentation before questions, or I should wait till each segment is presented for questions before going further, sir.
I think we can go the format that we've always followed. I don't know what other thing.
I agree.
What about the time? I hope we will not use more time.
No, sir.
Okay. You know, by the time people start their sending their question, we may use more time. Or if we do it the way we do it in the department, you know, at every segment, after presentation of the history or clerking, we ask questions. After examination, we ask questions. After that, diagnosis management, we also ask questions. You know, if we break it like that, we may end up spending more time. But if we just jot down our comment questions, and then at the end of your presentation, we now allow people to comment and ask questions. I don't know.
Okay, sir.
Let the consultant, the moderator, please.
Dr. Azogu.
Why don't we try what we are used to first and see how it goes?
Okay, then. So let's see whether we'll be able to keep within that 1 hour.
Okay.
Dr. Ejeba, please.
All right, sir. Is a 9-year-old female with left eye swelling of 3 days duration. She was apparently enjoying good vision until 3 days ago when she started having left eye swelling, which was gradual in onset, moderately painful, especially on eye movement, worsening with associated redness, mild mucoid eye discharge, double vision in all directions of gaze, but no diminished vision, no deviation of the eyeball, nor drooping of the eyelid. There was no history of something covering line of vision or seeing objects with missing parts. There was no history of seeing colors appearing faded, no history of seeing halos around light. There was no history of discharge, no eye itching, no history of foreign body sensation, no history of trauma to the eyes. The right eye is apparently normal. Prior to onset of eye swelling, there was 4-day history of left nasal pain and moderate grade intermittent fever. However, there was no history of vomiting, weakness, or loss of appetite. She initially presented to her pediatrician, who thought she had preseptal cellulitis and started her on amoxicillin. However, after 1 day on amoxicillin, the patient returned to her pediatrician because her symptoms were worsening. She was switched to augmentin and had 5 doses when she presented to the institution. The patient's pediatrician also ordered a maxillofacial CT at her return visit.
Excuse me. Excuse me. I thought you were going to just present the sign and symptoms instead of giving us the whole story about treatment and investigation, because that will defeat the purpose of this discussion. Sign
Okay.
and symptom running to a diagnosis.
Okay, ma. All right, ma.
Because if
Dr.
we start
Ejeba,
treatment, you're already
what guy is
distorting
saying.
our thought.
The way I thought this presentation would go, since we don't have a physical patient with us, it's like answering a question of a patient who presented with that. Just as we do it is, let's say they want you to manage that particular patient. The way
Yes,
you will take your history, what are
yes,
those questions you will ask?
yes, sir.
I don't know, the way you will click the patient. Then when you want to examine, what you will look out for, what you will see.
Yes, sir.
I thought that is how you're going to take it.
Yes, sir. Like this page now contains the body of the history. The one I was trying to present is the care the patient received before. So I don't know, because I asked Dr. Nwako, he said I should follow the presentation the way it was presented, and maybe a little modifications. So that was why I added this one as a form of care the patient received before presenting to the ophthalmologist, sir.
Dr. Ayeni, my thoughts are, if this patient were to present to us, the history would go exactly the way it's going.
Okay.
So I'm thinking, why don't we just allow it to
finish? Okay.
to finish? Yes.
Okay, let's see.
Okay. So in the past ocular history, there was no positive finding. There was no history of use of eyeglasses or use of traditional eye medications or trauma to the eyes or surgery, ocular surgery in the past. Medical history is essentially normal. The medications the patient was on before presentation to the ophthalmologist were augmentin, paracetamol, and codeine. There was no history of allergy. The family history is non-contributory. On review of system, there was fever, mild headache, catarrh, but there was no neck stiffness. That ends the history. Should I go on?
No, please. There's a question regarding the history. Can you look at question and answers and answer that question? Just it's a need for clarification on the history.
Okay. I can't see the question.
Click on question and answer. You will see the.
Okay, thanks. Please, is the double fissure worse in any distance? And is the redness of the eye recurrent? That is the question.
Is the, sorry, sir.
Please, is the double fissure worse in any distance? I don't know whether that question is.
It wasn't stated, sir. But it was stated that in all directions of gaze.
Is the redness of the eye recurrent? It's not my question, or is the one posted by Rosita?
Yes, sir.
It's when you say you didn't see. That's why I'm reading it.
Okay, sir. It wasn't stated if it was in far distance or near distance, but it was stated that it was in all directions of gaze.
Is the redness of eye recurrent?
No, sir.
Okay. Ejaye, want you to summarize the history.
Sir?
Dr. Ejeba, what is the summary of this case? Or there was no summary too?
There was, in summary, I present a 9-year-old girl who presented 3 days ago with left eye swelling with associated moderate pain and redness, and 4 days prior history of nasal pain with associated double vision.
The first question that was asked, do you think is relevant?
Yes, sir. It is relevant, sir.
What's the relevance?
It depends on the cause of the diplopia or the double vision. For example, a patient with strabismus. Sorry, sir, I don't really get, sir. I can't really get the explanation.
Can Dr. Rosita help us?
Is Dr. Okay, please, can we unmute Dr. Rosita, please? Maybe she wants to help us. Eye focus team. Dr. Rosita is muted.
Why is it not unmuting?
Maybe we should proceed if she cannot speak to us at this time.
Okay,
Are we
Dr.
done with
Ejeba.
are we done with the resident questions? Because I have questions for Ejeba.
But she can unmute herself. Who is Dr. Rosita? Unmute. Just touch the button at the bottom of the mute button. Aha, there you are.
Good morning, ma. Good morning, everybody.
Mm-hmm.
Good morning, everybody.
Good morning.
Yeah, we can hear you. Good morning.
I was thinking that double vision it can change depending on the refractive state of the patient. Can you hear me, ma?
Yes, we can hear you.
I was thinking that the double vision it varies or it worsens depending on the refractive state of the eye. Like if the object is far, maybe a myope, it worsen for myopes. So that's my explanation. That's what I thought.
It sounds a bit confusing to me. I think we should just ignore it and proceed.
Okay, Prof said he has some question for Ejeba.
Okay, Dr. Ejeba, thank you so much.
Yes, sir.
I just want you to explain, based on this history you give us, why do you think this patient is having mucoid discharge? However might, then can you explain why the patient, or attempt to explain why the patient is having diplopia, or account for it, as well as the pain? Those three things: mucoid discharge, diplopia, and pain.
Okay, sir. The patient presented with left eye swelling of 3 days duration,
Okay.
with pain. However, 4 days prior to onset of this symptom, the patient started having left nasal pain. And from the history, where the history is taking us to, nasal problems, maybe in form of sinusitis, rhinosinusitis, it can progress to give this eye symptom and sign as a complication. So the patient having nasal pain and nasal discharge, and later having eye discharge on that same half of the face, that's the left eye and the left nose. It can explain why the patient has a mucoid eye discharge, as well as the pain. As for the double vision, if whatever that is going on in there has a compressive effect on the globe, the patient can begin to have double vision. So that's the explanation, sir.
Okay, classically, mucoidal discharge is produced when? When do you have mucoidal discharge classically?
In conjunctivitis, allergic conjunctivitis.
Is it caused by irritation?
Sorry, sir.
Can it be caused by irritation? Maybe something
Irritation.
rubbing on another.
Um, it's possible, sir.
Okay. There is, most likely there is swelling.
Sir?
Eyeballs, they are likely to be not aligned. Can that one produce double vision?
Sir, I didn't hear you, sir.
The two eyes,
Yes,
because
sir.
one is somehow swollen, Abi.
Yeah, the
I
left eye
say
is swollen.
misalignment
Yes, sir.
of the eye, can it cause double vision in this case?
It can, sir.
Okay.
Yes,
I
sir.
just want to know that you understand why you have all these either symptom or signs or
Yes,
whatever
sir.
you want to list them.
Yes, sir.
You can classify them as signs, you can classify them as symptoms. You
Yes,
are
sir.
getting well, some of them or all of them.
Okay,
Even
sir.
if you don't, if you may not know that the patient is having pain, patient can express it. But when you are examining and patient is showing certain facial expression, you can also pick it as a sign that this patient is having pain. Something like that. Thank you.
Yes, sir. All right, sir. Thank you, sir.
Just to add to what Prof said, typically when you have diplopia, what are you thinking of? You're thinking of an alignment problem. Is that not so?
Yes, sir.
And what typically causes ocular misalignment?
Ocular misalignment.
What typically causes it?
If there is weakness of the extraocular muscle, sir.
Okay, which could be from?
It could be from trauma, from inflammatory processes or infective processes.
Okay, so it could be from the innervation. Hmm?
Yes, sir. Yes, sir. From innovation. Yes, sir.
So a nerve problem, or it could be from a local problem,
Yes, sir.
to the
Yes, sir.
muscle itself. So
Yes,
in
sir.
this instance, what are you thinking of?
In this instance, it's more of a compressive problem, sir, on the globe.
And what tissue exactly are you thinking of is involved?
The orbital soft tissue, sir.
Orbital soft tissue, which includes the muscles as well. Is that not so?
Yes, sir.
It's all right. You can proceed.
Okay, sir.
Dr. Jeba, oh yeah, now let's listen to your examination.
On ocular examination, the distant visual acuity with best correction on the right eye was 6.6. On the left eye, it was 6.6. The pupils examination, it was 4 millimeters in the dark room and constricted to 2 millimeters on exposure to light. It is brisk, equal, and there was no relative afferent pupillary defect in both eyes. On ocular motility, the right eye was normal, but on the left eye, there was restriction of movement of -1 in adduction and superior gaze, and reduction in movement of -2 in abduction. And there was diplopia in all field of gaze. External examination using Hartel's exophthalmometer, the right eye was 13 millimeters, while the left eye was 15 millimeters with a base of 93 millimeters. From this finding, there was a difference of up to 2, which is significant for proptosis. And the palpebral fissure was on the right eye 9 millimeters and on the left eye 7 millimeters. The marginal reflex distance was 5 millimeters on the right and left, and 3 millimeters on the left. The laser lashes were normal on the right eye, but there was erythematous, edematous upper and lower lids with proptosis. The conjunctiva in both eyes were normal. Cornea was normal in both eyes. In the anterior chamber, it was well formed. There was no cell or flare in both eyes. The lens was normal. Vitreous, there was no cell in the vitreous in both eyes. Fundoscopy was not done for this patient. And there was no particular explanation given for that. Thank you.
Okay, Dr. Ejeba, my own question would be, suppose this patient presented to you, what are the other things you would have loved to do that was not done for this patient in your examination?
Okay, in my examination, after doing the general examination and systemic examination, in the ocular examination, what was left out of the examination here was fundoscopy and color vision tests. But every other thing was included in the examination, sir.
All of the intraocular pressure.
Sorry, it was checked. Sorry, I failed to mention it. On the right eye, it was 14, and on the left eye, it was 23 millimeters mercury. And confrontational field was full in both.
Please, if we have comment or question, can raise up your hand or you send your question so that we can make progress. Okay, if we are satisfied with the examination,
I have a query for him.
Prof, let's hear your query, sir.
If residents are not asking him questions. Okay, looking at some of these parameters you roll out,
Yes, sir.
I want to believe the palpebral fissure, is it 13 for? Then first, can you explain to us what OD, OS, OU means? Latinize something, Latin form of it.
Yes, sir. OD is oculus dextra.
Okay.
That's a Latin term for the right eye.
Okay.
Then OS is oculus sinister for the left eye. Then OU is oculus uteca. That's for both eyes.
Okay. The source of your in this case is America,
Yes, sir.
You okay? In fact, I'm surprised they are using CC because they use feet in America.
Sir?
I need the visual acuity. The visual acuity, I was all you are the one that converted it to meters. The visual acuity.
Yes, sir.
Because I
Yes, I
characterize
was the one that converted it.
Okay. I know they are the one using all this ODOS. If it is a British, you will just see RE, LE. The fissure, that of the left was smaller than that of the right.
Yes, sir.
Can you explain the reason? Can it be the reason why fundoscopy is not done? Can you account for why fundoscopy was not attempted? What is your position? Because you just explain it out that it didn't state the reason. Can you account for why it was not done? And what is your position on skipping fundoscopy in this particular case? And when was this patient, when was he seen? How long ago?
That was
I'm just giving you the clue to what you can say to answer this particular reason why fundoscopy was not done.
okay, sir. I don't think it's due to the finding on the palpebral fissure measurement, because the difference in both eyes. Hello, sir.
I'm listening to you.
Okay, sir. Because the difference in both eyes is 2, and for a unilateral ptosis, for mild is up to 2 millimeters, for moderate is 3 millimeters, and for severe is 4 or more millimeters. So in this patient, it was a mild case of ptosis, which ordinarily shouldn't prevent someone from doing fundoscopy. However, maybe due to the acute nature of the illness, maybe patient having photophobia, which was not actually stated, fundoscopy was skipped.
What could be another reason? Since they didn't state it, I want you to account for it. What could have been another reason that may want to make you defer fundoscopy? In this particular case, fundoscopy is very, very necessary, very, very essential as part of your management. You are getting one, but they skip it. What could have been another very good reason why it can be skipped? Why are you at home now? I've been coming to the hospital, and once you are in the hospital, whether you like it or not, you have to see patients. Whether
Yes,
relation of the staff, whether those that will just stray around, you are getting what I'm saying. But
yes,
believe you me, all those one have been seen. I don't do fundoscopy now, honestly,
yes,
because I don't have PPE. The best I have with me is this face mask. You are getting what I'm saying.
yes, sir.
And can that one be the reason?
Yes, sir. It can be a reason, sir.
And then let me be frank with you. If I see any, though they say just mild mucous discharge, if there is this infective condition, honestly, sometimes I don't do fundoscopy because experience has taught me that I've caught eye infection before from infective conjunctivitis. You are getting what I'm saying?
Yes, sir.
I defer fundoscopy when I know it's not safe for me, something like that. So, but in this case, I don't know. But we have to just to advance listen why because it's very, very necessary in this particular. Though I've not seen your diagnosis, but what my mind is telling me, if it is, there's need for you to do fundoscopy.
Yes, sir.
If I may ask, Dr. Ejaba,
Yes, sir.
if you were to do fundoscopy for this patient, how would you go about it?
If I'm to do fundoscopy for the patient, I could use indirect fundoscopy instead of direct fundoscopy to avoid minimal contact with the eye.
Assuming we're not in the middle of an outbreak,
Yes, sir.
a contagion, and every other thing was normal, how would you do fundoscopy for this patient?
If the ptosis is covering part of the pupil, I would try to um, move it away to be able to have a view of the pupil, then then take the normal steps in direct fundoscopy um, procedure, sir.
You've not told me the instrument you're going to use.
Sorry, sir. Ophthalmoscope.
Ophthalmoscope.
Yes, sir.
Ophthalmoscope, is that the right instrument for doing proper fundoscopy?
Sorry, sir. I don't get your question, sir.
I said, is that the right instrument for doing fundoscopy of fundus examination?
There are different types of fundus examinations, sir. The direct fundoscopy with the use of ophthalmoscope, then the indirect with the use of binocular indirect or ophthalmoscope, or use of slit lamp with the aid of 78D or 90D lens.
Okay, yeah. For your information, in the developed world, most of the developed world, they don't direct ophthalmoscope is not used for fundus examination.
Okay, sir.
Mm? And that may be part of the reason. So if that being the case, what other reason do you think could account for the fact that fundoscopy wasn't done?
I can't think of any reasons other than
Because
it's a 9-year-old that should cooperate, except based on the acute nature of the illness, she cannot cooperate. Other than that, I don't know of any reason, any other reason.
It's okay. Let's take other questions.
Are you done, sir?
Yes, I'm done.
Okay, I want him to account for the intraocular prayer. Why do you think the prayer in the left eye was 23? Why on the right it's 14? If you want to comment on the
Yes, sir. Because of the proptosis, is an indication that there is an increased orbital volume, and when there is an increased orbital volume, it can have direct impact on the intraocular pressure, leading to a high intraocular pressure as indicated in the left eye, sir.
campaign also pain
Yes, sir. Pain also can.
and level of cooperative if the patient is not cooperative too. And then which type of tonometer will you prefer in this case?
I'll prefer a non-contact tonometer.
Thank you. Progress.
Dr. Ejeba, sorry, just look at I think there were some questions that were posted, so that you
Okay.
quickly look at them.
Okay, sir. Dr. Keta's question. I don't think a difference of 2 millimeters is significant for prognosis, for proptosis, like you said. Some sources said 2 millimeters and above. Others say them above 2 millimeters. So I don't know. I think 2 millimeters is significant based on some school of thoughts. Then the difference in margin reflex distance, is it pointing to ptosis or lid retraction? I think it's pointing to ptosis. Any reason to why the pupil findings were reported earlier than the conjunctiva, cornea, and anterior chamber? There was no particular reason. We in the department and in this environment, we have a particular pattern of reporting our ocular findings. But this, like I said, this patient was in this country. I think this is the pattern they follow over there. And so there was no need to actually change their examination findings. That was why it was presented like this. Thank you.
I like that critical mind. But when you can spot the difference between what you do and what is done elsewhere, is a good it point to critical mind. So thank you, Damte, for that.
Okay, please, Dr. Jeba, can we quickly look at what they thought, what was their differential diagnosis, or what was your own differential diagnosis?
Okay, sir. So there, should I go ahead with the laboratory investigation, sir?
Yes, let's see what they did.
Maybe at this point we can change it up a little bit. And based on your presentation, tell us what your differentials are.
Okay, sir. Based on the presentation, the first differential will be orbital cellulitis, precellular cellulitis, sorry, preseptal cellulitis.
Sorry, for whatever diagnosis you give us your reason.
Okay, sir. Orbital cellulitis, because of from the history of 3 days history of left eye swelling with pain, especially on movement of the eyeball. Then history of double vision in all directions of gaze, fever, redness of the eye. That's from the history. Then from the examination, from the exophthalmometry, Hartel's exophthalmometry, which showed a mild proptosis.
Sorry to interrupt you. The way you answered that first part, I wasn't very satisfied.
Okay,
can you go this way? The symptoms of redness and pain
yes,
are pointing to what? An inflammatory or infectious problem, Abby?
yes, sir.
The proptosis, pain, and restriction of movement are pointing to orbital, soft tissue inflammatory process.
Yes, sir. Yes, sir.
So maybe you go that way so that we know that you're linking the symptoms to a particular pathological process.
Oh, okay, sir. The patient has pain on ocular movement, redness, which points to an inflammatory infective process. In this case, orbital cellulitis, any inflammatory conditions of the orbit, like orbital cellulitis, preseptal cellulitis, even orbital abscess can give this kind of symptoms.
Preceptor cellulitis, would you expect proptosis and pain on eye movement?
No, sir. You will not expect proptosis or pain on eye movements.
So why are you linking preceptor cellulitis to those symptoms?
So he has withdrawn that one. Oh yeah, Dr. Ejemba, continue.
Yes, sir. So cavernous sinus thrombosis can be a differential, and at the same time
Wait. You've not finished with the orbital cellulitis now. Maybe I thought you were going to, like Dr. Azubu said, each of the symptoms, or group of symptoms, you
yes,
say
sir.
it that are present, and tell us why it's there. You understand, ba?
Yes, sir.
Then if there are other symptoms, you finish with that. Then you finish with maybe on your examination what and what you found that is still linking to orbital cellulitis, like that. You
Okay,
understand, but then before you now go to other, other differentials.
Let them wait.
yes, sir. So for the first differential, orbital cellulitis, because of proptosis, redness of the eye, pain on ocular movement, fever, and double vision. Based on these symptoms, I think orbital cellulitis is the first diagnosis. Then on examination, there was mild proptosis, but there was no chemosis. There was restriction of ocular movement on the left eye and increased intraocular pressure on the left eye. So from those examination findings, orbital cellulitis is the first differential. Then other differentials, like cavernous sinus thrombosis. In cavernous sinus thrombosis, there can be severe pain.
Sorry to interrupt you again.
Yes, sir.
Cavernous sinus thrombosis is at the other end of the spectrum. Why jump to that? Are there any other differentials? Okay, what are the differentials of orbital cellulitis?
Yes, sir. Differentials of orbital cellulitis. Can you hear me, sir?
Yes, I can hear you.
Hello, sir.
I can hear you.
Can you hear me? Yes, sir. Differentials
Yes.
of orbital cellulitis. Hello, sir.
Dr. Ejeba, go on now. We are hearing you.
Okay, so differentials of orbital cellulitis. Orbital abscess, orbital hemorrhage, that's retrobulbar hemorrhage, cavernous sinus thrombosis.
Again.
Ejeba,
Yes, sir.
I think you should work from the first principle. From our routine something, we have agreed that whenever you are mentioned differential, you should be able to tell us, okay, positive things, not just dropping names. Positive things, then negative things, not just dropping names. Cavernous sinus thrombosis, orbital tumor. If you don't do it that way, you must tell us why you think it can be cavernous sinus thrombosis or orbital abscess, rather than you are getting one. You tell us those things that can make orbital abscess to look like orbital cellulite, all those things you need to tell us, not just be dropping names.
Yes, sir. So
Yeah, I think we are past that stage.
Yes, sir. Orbital abscess. In this patient, there was swelling of the left. You can have such, and you can have pain too, or ocular movement, and double vision, and there can be fever because of systemic spread. There can be fever. Then on examination,
what is the characteristic of fever in abscess? In any abscess, anywhere in the body, what is characteristic pattern? Don't throw away all those basic things you know. You need to add them together to make a whole something. And then whoever is listening to you will like you when you are organized.
there's a characteristics of fever. Hello, sir.
Continue. Everybody is hearing you.
Okay, characteristics of fever in orbital abscess. It can be low grade to moderate grade, and it can be intermittent.
Are there any non-infectious inflammatory conditions that can simulate orbital cellulitis?
Non-inflammatory orbital conditions, yes, sir.
Like?
Like orbital foreign body, parasitic cyst, dermoid cyst.
How can dermoid cyst give us an orbital inflammation?
You say non-inflammatory, sir?
I said non-infectious inflammatory conditions.
Okay, non-infection.
Oh, okay, okay. Dermoid cyst is not part of it.
Even dermoid cyst is part of it, but you need to know the pathophysiology. But let's not dwell on that. Give me some non-infectious inflammatory conditions. Have you heard of idiopathic orbital inflammatory disease? Used to be known as orbital
Sir.
Have you heard of
Which?
orbital pseudotumor?
Pseudotumor, yes, sir.
Can it be a differential in this situation?
Yes, sir. It can be a differential. Optic nerve glioma too can be a differential. But in optic nerve glioma, you may not have
optic nerve
signs
glioma.
of
Is it
inflammation, but they
an
can.
Inflammatory?
No, it's not an inflammatory process, but it can give the diplopia and the protrusion and proptosis.
Dr. Ijeba,
Yes.
you're not sounding like you really prepared well for this presentation.
If you listen to his question,